Very good. Well, thank you so much. What an honor to be involved here with such illustrious faculty. And this was the basis of a very interesting case series discussion that we had before. And I want to acknowledge my chief resident, Natalie Gooley, who was unable to be here today. She really wanted to be here, but due to commitments, she couldn't do it. But a lot of this is stemming from her work. We really just want to give you a very brief historical kind of background to central cord syndrome and touch on some of the controversies that Dr. Harrop will be touching on lately, and Dr. Daly. So basically, central cord syndrome is a little bit of a misnomer. I wish it wasn't called that. It really is an incomplete cervical spinal cord injury. It was actually first described in 1887, but Rick Schneider really did bring it into the neurosurgical folklore through his publication in the Journal of Neurosurgery in 1954. His definitive publication at the time explaining the potential pathophysiology, but most importantly, the clinical features of it, raised interest in this entity. And this is him here with Edgar Kahn and Elizabeth Crosby doing some of their anatomical dissection work, which they were famous for. So very, very interesting. So I want to quote, this is an interesting quote that we pulled from his paper. And it reads, "In acute cervical spinal cord injuries, there is a syndrome that suggests central cervical spinal cord involvement, characterized by disproportionately more impairment of the upper than of the lower extremities, bladder dysfunction, usually urinary retention, and varying degrees of sensory loss below the level of the lesion. The lower extremities tend to recover motor power first, bladder function returns next, and finally, strength in the upper extremities reappears." And that is pretty much the definition of central cord syndrome. Remember, it is a clinical entity. It's not really a pathological entity at all. They're all part of incomplete cervical spinal cord injuries, but it's a clinical entity that we've decided to pull together. And some of the problems with it is that it is an incomplete injury and should be treated as such, and that'll feature in the controversies of treatment. But this was the first case example that he used in the paper, and you can see that there. And essentially, he describes a gentleman that tripped on a rug, fell directly forward on his face, striking his forehead on the floor. And we've seen that this is the classic kind of clinical presentation. Was numb and paralyzed in all four extremities. Most of his numbness vanished after a few days. He regained some degree of motor in his legs, but much less in his upper extremities. And there he describes kind of the X-ray picture. You can see a bone spur being hinted at there ventrally. There's a myelogram which shows constriction at C3-4. And then most amazingly, his treatment, he took the patient to OR, and in the OR, not only was a cervical laminectomy done, but the dura was opened, a decompression was done directly, and then the dentate ligaments were sectioned in order to give the cord as much room as possible. Well, the problem was that the patient became worse after the operation than before. And the premise was that the cord was moved laterally in order to be able to really free this cervical cord. In addition to this, he actually, in some cases, they explored ventrally, opened the dura, and removed osteophytes ventrally. So it's quite incredible. I don't think that anyone has repeated that in recent times. But he came up with a proposed mechanism, and he worked with this gentleman, A.R. Taylor, who's fascinating. But basically, this gentleman did a lot of the myelograms back then, and they would do myelography on normal cadavers. And you can see the normal spine or the spine in normal alignment there, flexion next to it, hyperextension, and then in the normal cervical position there. And the proposed mechanism was that there would be this hyperextension injury where the cord would be dinged, if you like, across multiple levels of cervical spondylosis with buckling of the ligamentum flavum, superimposed with whatever disc there was ventrally or bone spurs, as was described. And the combination of this compressive kind of injury from ventral and dorsal would lead to this spinal cord injury. And his colleague actually went one step further and basically made a plastic model of the spinal cord section and laid out in somatotropic kind of representation and demonstrated through compression both ventrally and posteriorly what would happen to the cord and how it would be stretched. And he came up with a pathophysiological theory behind how central cord would occur. And that was that some of these fibers that were as part of the lateral corticospinal tract, somatotopically, the cervical fibers were represented more medially as part of that lateral corticospinal tract representation within the cross-section of the spinal cord, and hence the region most impacted, which was central, would impact the cervical fibers and hence the upper extremity much more than the lower extremity. And that theory stuck until modern times when we've now re-questioned it. And there's been great new, basically through elastography, through electron microscopy and other kind of modalities, we've been able to dispute it. So in his conclusion, without bony involvement, in other words, without some compressive pathology, surgery became contraindicated. And that was because these patients would spontaneously recover when there was no, in patients with no discrete area of compression to relieve, the edema of the spinal cord would be longitudinal, so it would spread up and down, and there wasn't a focal area in the cord to actually decompress. So there wasn't anything at the point of impact, and that surgery was likely to make patients worse. Well, that's kind of intuitive given the surgical involvement that he had. But what that did was impact surgical decision-making for these patients for several decades. And it really wasn't until the 80s and the 90s when we started to question this. And we took this paper from the late 1990s. This was a Taiwanese paper. And it kind of explored a new role for potential surgery. And going through it, it's kind of interesting. So their paper was a retrospective review of 114 patients. It was from their single center in 1988 to 1994. These patients were collected. 28 of these patients were managed surgically. 86 were managed medically. So anything non-operative, including if there was a compressive lesion. And they looked at various different modalities, including age, what the injury was, what the initial presentation was, X-ray findings, and whether or not they had surgery leading to functional recovery or not. And basically, what they excluded 3 patients who were operated on very late. But out of the 28 group, they really listed them very carefully with respect to the imaging findings, and in this surgical group, what they did, where they thought the compressive lesion was, whether the patient was stable or not, and how they approached it. And it's kind of interesting. Most of their operative approach to this was anterior. So they went from the front and did their anterior cervical discectomy and decompressions. And what they found, and the average time for OR, for taking the patient for decompression, was approximately 10 days. So we definitely wouldn't consider that early today. But their decision to operate was based on whether the patient failed to improve, whether there was difficulty with activities of daily living, whether they were getting worse, whether there was gross instability, and so on. And so, interestingly, as a control group, they had 11 patients with compressive pathology who were managed medically, and this was the group here. And the results were kind of interesting. So regardless of whatever treatment these patients had, self-voiding and walking basically improved with time, and on average it was less than 6 days. This is if you put everybody together. And so there was a slow but steady improvement of hand function overall, even in the non-operative group. And you can see that there. The dots at the beginning on the left side of the graph there represent how they presented with lower numerical grading in terms of hand strength. And then over a 7-day to 30-day period, you can see an improvement in the motor grade, motor score. But the interesting finding when they parsed this out was that the surgical group actually had a shorter length of recovery with respect to the non-operative group. And this table here represents the surgical group, and you can kind of see each number in that table represents a specific patient in the list of 28 patients. And starting from at the time immediately preoperatively to all the way up to 3 months, you can see this kind of linear change pretty dramatically between low motor score with respect to strength and hand grip, all the way to higher muscle strength. Now, when they parse this out for the non-operative group, there really isn't that direct linear correlation. And some patients improved, as was the expectation for the natural history of central cord syndrome, but a lot of patients plateaued. And so they never went past what they achieved with their Asia C classification. And so it's very interesting. Their conclusion was that early operation might actually result in better outcomes in these selected cases where there was compressive pathology. And they postulated that there was a vascular component to it, or there's dynamic instability that led to an ongoing pincer mechanism in those lesions. So if you stabilized that, you avoided micromotion and ongoing pincer compression of the cord. So all the way up to a much more current study done with some of our illustrious faculty, like I said here, in 2019 as part of the AO group here, that basically took the studies from all the way from Schneider to studies done in the 2000s and looked at this kind of historical progression of what these studies demonstrated. And the red demonstrates no value or recommendation for surgery. And as you can see, with time and over the decades, we went from accepting that surgical treatment was not useful and not likely to benefit the patient to patients improving up to 1 to 2 levels in grade, in Asia score, over a 3-month period with surgical treatment. There was still large sample size studies which didn't demonstrate benefit with surgery, but overall, there was a trend here. And so the findings were that central cord syndrome does have the inherent potential with its natural history to improve regardless of whether you operate or not. The extent of the recovery was directly related to the severity of the initial injury, which stands to reason. But it raised the important question that would recovery be potentially faster with surgical treatment than without? And would it be better? Would we have higher grades of improvement with surgical treatment? And so the conclusion was that surgical treatment, patients with surgical treatment recover faster, they have a shorter length of stay, but long-term follow-up has failed to demonstrate a difference in functional recovery overall. And so their conclusion was that in patients with mechanical instability or ongoing compression, surgery should be the mainstay of treatment. Okay, so data demonstrating that surgery is effective. Okay, what about timing? And this is kind of the real interesting study here. And I know that this will be addressed later, so I don't want to kind of steal anybody's thunder. But the Staskas trial from 2012 looked at 182 patients that underwent early surgery versus 131 after 24 hours from this multi-center international trial, 16 to 80-year-olds, 300 patients in total. And basically, it was a multivariate regression analysis that confirmed that patients who underwent early surgery, as defined by 24 hours or less, were likely to improve at least 2 grades at follow-up. But the problem was that this was all comers, and it wasn't clear what subset of this was the central cord group. So all the way up to 2022. This I think, is kind of our latest findings. A very interesting study that took the data from 3 large prospective trials, the Spinal Cord Registry, North American Spinal Cord Registry, the STASCUS and the NASCUS, and put it together and effectively performed a propensity score matching breakdown between those that were operated less than 24 hours to those more than 24 hours, which were defined as late surgery, and looked at results with follow-up. And this is interesting. They looked at upper extremity motor score, and they found that to be significant in terms of a difference between early to late. Lower extremity motor score and overall motor score, there were significant differences. You can kind of see that the study was powered enough to be able to demonstrate that. So I love this line. You know, Dr. Failings kind of really emphasizes it, and the fact that time is spine. We all say that time is brain when it comes to various cranial entities like stroke and decompressive hemicraniectomies and so on. Well, really, time is spine as well when it comes to compressive lesions in this entity of central cord syndrome. And this was a reply by David Okonkwo to that paper, and I just want to read it. The options are to decompress early or not. Although literature can be cited to defend a delay in surgical decompression, there's not a benefit in doing so. On the other hand, the possible gain to be made from early decompression is too great to ignore clinically. And I think that kind of nicely lays out the consideration here. So a couple of things to end with. Medical management of central cord syndrome. It really begins from the time of injury. And we tend to think of, you know, this being a surgical entity, which it is. But there is so many parameters and modalities that probably should be considered to avoid a secondary injury to the spinal cord. So this study by Fernando Valle, all the way back from 1997, single institution study, but it was prospective. They decided to select 85 as a map parameter. And although I'm not, totally knowledgeable as to how 85 was decided, it's interesting that was, I think it was extrapolated from data on cerebral perfusion pressures, basically, after mild to moderate TBI. But some of the faculty may know more about that. But essentially, what they did was they looked at maintaining that map for a 7-day period, whether or not the patient required pressure support to keep the map goal at 85 or above. And they included cervical, thoracic patients, various mechanisms, various severities, and they essentially found that it was safe and feasible to implement this. And very interestingly, even in patients that presented with an ASIA A grading, at 12 months follow-up, there were ones with dramatic improvement to a much improved recovery. And so they saw improvements. The problem was that there was no control group. So there was no definitive recommendation able to be made with it. Looking back, this study from 2017 looked back at map parameters through a systematic review, 11 papers, and they found that no randomized studies had been done, but they recommended it nonetheless. And one study in particular that had a control group here demonstrated benefit, and that was an interesting study. To conclude with, this is our last point here, spinal cord perfusion. So we talk about optimizing these patients. So just like the brain, where we want to optimize the cerebral perfusion pressure, should we not be thinking of spinal cord perfusion pressure as well? And measuring intraspinal or intrathecal pressure through a monitor, lumbar drain, and manipulating either our MAPS, our mean arterial pressure goals, or trying to decrease intraspinal pressure to maintain an adequate spinal cord perfusion pressure. And this number of 65 has been selected. There's some data on it. I think much more importantly is all of it put together. Avoiding hypotension is probably the key. Correcting other injuries, looking at inspiratory pressure post-op in the ICU setting, a VQ mismatch, and so on. But that's just a very brief introduction to central cord syndrome. Thank you.
Thanks so much. Thanks so much, Noojan. We'll hold questions till the end of the session. We're going to move into